research. Very grateful to Professor Peter Dwyer for being an amazing mentor, and very grateful to Professor Wolfgang Umek for his amazing local hospitality during my stay in Vienna. We don't have any disclosures for this talk, and my co-authors are Professor Peter Dwyer and my colleague Payam Nikpur. So topic of our study is simple closure with conservation of sling versus excision for tape extrusion, which provides the best outcome. So synthetic mid-urethral sling is the most common anti-incontinence surgery performed globally for stress incontinence. Vaginal tape extrusion occurs in 1 to 3% of women and is an important cause of morbidity and litigation despite the overall small risk. Simple closure with conservation of the sling is attractive as it maintains sling integrity, and the American College of Obstetricians and Gynecologists committee report suggests that this could be tried as a first-line, minimally invasive or conservative option. It also helps preserve continence, but does it indeed provide best outcomes? And this is what we are going to look at. So the objectives of the study was to compare vaginal closure with versus without sling excision in the management of vaginal tape extrusion. So materials and methods, we looked at surgically managed cases of extrusions in our hospital, which is a tertiary urogynecological center in Australia. So we had about 2,823 women as part of 2 ongoing database studies, and all these women had urodynamic stress incontinence and had a mid-urethral sling cited between 1999 and 2017. There were 2,310 retropubic and 498 transobturator slings and 15 single incision slings. So about 1% women had tape extrusion, 22 women had a retropubic sling sited, and 11 had a transobturator sling. Sling extrusions were mainly in the midline with retropubic sling, so 19 out of 20, and mainly lateral with transobturator slings, 8 out of 11. Out of these 33 women, 31 needed surgical management, and revisions for pain or voiding difficulty were excluded, and they're part of a separate study. 15 out of 20 extrusions following retropubic mid-urethral sling were midline, and 5 were lateral. 3 of the extrusions following transobturator approach were midline and 8 lateral. This shows the previously given information and gives a clearer overview of the distribution of patients and their extrusion characteristics. This is a midline sling extrusion, which was dealt with by one of the 2 methods which we are going to describe, and this is the final result of that. So the mean follow-up was 100 months. We did do a logistic regression analysis and older age, body mass index, diabetes mellitus, current smoking, the operator being a trainee, recurrent vaginal/incontinence surgery, retropubic approach in a patient with intrinsic sphincter deficiency were independent risk factors for mesh extrusion. The sling revisions were classified as simple closure with conservation of sling versus excision and repair. The demographic, urodynamic, and procedural variables were similar at baseline between the 2 groups. So coming to the results, 19 of the 20 patients had successful closure following sling excision. 1 of these patients required a further procedure to deal with lateral extrusion detected 6 months later. Out of the 11 who had vaginal closure alone with sling conservation 7 out of 11 who had a vaginal closure alone with sling conservation needed a second procedure for recurrent extrusion. The vaginal portion of the sling was removed and no stress incontinence procedure was performed. 2 of the 7 required further stress incontinence surgery with 2 reporting persistent pain. 5 out of the 20 who had sling excision had concomitant stress incontinence procedure performed with no recurrence of stress incontinence. 5 out of the 15 who had sling excision alone needed further stress incontinence surgery. Out of the 11 women who had sling conservation, 7 required reoperation for recurrent extrusion. Recurrent stress incontinence did not occur in any of the 4 who had successful closure. Of the 22 who had partial/complete excision of sling eventually and did not have a concomitant stress incontinence procedure at the time of revision, 7 had further continence procedures, so about 1/3. Overall, out of 31 patients in the series, 7 needed a further continence procedure, about 22%. Failure, which is defined as resolution, non-resolution of extrusion and or needing a second revision for extrusion, is significantly higher in the simple closure group with a p-value of 0.0048. So this diagram essentially reiterates the results which we have just discussed. As we can see, out of the 7 patients who needed further stress incontinence surgery, 5 had midurethral sling, 1 had pubovaginal sling, and 1 had Birch colpo suspension. I'm going to leave the slide on for the next few seconds for the audience to visualize the information. Coming to the conclusions, vaginal sling excision and repair has significantly better outcomes compared to vaginal closure with tape conservation. 1 in 3 women following partial/complete sling removal will redevelop stress incontinence and require further surgery. The placement of another synthetic midurethral sling at the time of sling removal will reduce the incidence of further stress incontinence but risks serious infection. Coming to the clinical and scientific significance, extrusion, excision with partial sling removal and the placement of a new midurethral sling has low risk of recurrent extrusion and excellent long-term continence. However, there is a risk of severe infection. The risk of intraoperative injury to urethral or bladder, particularly in the presence of scarring, needs discussion. The strength of our study, it's a large database study spanning over 18 years with good long-term follow-up. It suffers from the drawbacks of not being randomized prospectively. To some extent, we did overcome this drawback by an ongoing current follow-up, which was conducted by the nurses calling the patients to check on their continence and extrusion symptoms. Thank you.
It's probably quite a good practical study for you to take home, the messages from that. And finally, we have just a 5-minute presentation from Joanna D'Souza, based in the UK.
What is vault prolapse? In this study,
Joanna actually got 2 prize-winning abstracts, but we'll just play the first one. Thanks.
I don't know why it won't close. How's that? This one, right?
Yeah.
Hello, my name's Dr. Joanna D'Souza, and I'm a research fellow working at Southampton University. I'd like to thank Lindsay Hayward for accepting this research for presentation for the IUGA Academy. The research is entitled Risk Factors for Obstetric Anal Sphincter Injuries at Vaginal Birth After Caesarean Section. Research has shown that vaginal birth after caesarean section, or VBAC, is associated with obstetric anal sphincter injuries, or OASIS. However, little research has gone into the specific baseline characteristics and urgency of caesarean section at the first delivery, and what happens to the subsequent vaginal delivery outcomes, especially with regards to sustaining OASIS. Our study design was a retrospective analysis of prospectively collected data from an obstetric database. And comparisons of maternal, intrapartum and neonatal factors were made between those sustaining OASIS at VBAC with those whom did not. The selection criteria was secundiparous women with a previous caesarean section achieving singleton-term cephalic vaginal delivery, and the study period was between 2004 and 2014. Within the study period, 1,375 women had VBAC delivery. 86.6% sustained perineal trauma, whether that be spontaneous or facilitated. The OASIS rate was 8.1%, and the vast majority of women sustained either a 3A or a 3B tear. This rate of 8.1% is 4.3 times the contemporaneous multiparous rate of Oasis in women who have had previous vaginal delivery, and it's 1.4 times the primiparous vaginal delivery rate. Looking at it more closely, the most common outcome was a mediolateral episiotomy. This was in just under half of the population. The next common outcome was a second-degree tear. Those sustaining Oasis at VBAC had significantly heavier babies with a greater proportion over 4 kilograms. There was no difference as to whether or not the deliveries were operative. However, those sustaining Oasis at VBAC had significantly more prevalence of the use of forceps. The episiotomy rate was significantly lower in the cohort who sustained an Oasis, and that was regardless of the mode of delivery. Although not statistically significant, women sustaining Oasis at VBAC were 2.5 times more likely to have had shoulder dystocia. No significant differences were seen whether the delivery was post-term, whether there was an induction of labour, whether regional anaesthesia was used, the head position was occiput posterior, or in the length of second stage of labour. Those sustaining Oasis at VBAC had significantly heavier babies at the first delivery, and they were more likely to have had a more urgent category of caesarean section. No significant differences were seen as to whether the delivery was post-term, whether the caesarean followed induction of labour, whether the caesarean was in labour, whether the fetus was non-cephalically positioned, or in how dilated the cervix was at time of caesarean section. Factors that remained after binary logistic regression showed that having a baby greater than 4 kilos at VBAC doubled the risks of Oasis, as did having an emergency caesarean section at the initial delivery. Mediolateral episiotomy reduced the risk of Oasis by half. So the conclusions are that VBAC risk of Oasis is actually greater than the primiparous risk. Women who are older mothers, have larger babies, are at increased risk of Oasis at VBAC. And episiotomy is strongly protective against Oasis, and that's independent of the mode of delivery, with a number needed to treat of 6.8. 6.8 episiotomies to prevent 1 Oasis. Emergency caesarean section is a strong predictor of Oasis at VBAC, and this supports the speculation of relative cephalopelvic disproportion. Currently, a successful VBAC is an infant being born vaginally and with no consideration to the impact that this may have on the perineum. So this highlights that there's a need for improvement in VBAC candidate selection and counselling of women who are having a VBAC. Many thanks.
We can stop it there.
I'd like to thank the IUGA committee.
All right. There is one more, but I think you probably... Have you all had enough, or do you want 5 more minutes? Had enough, I suspect. Want it? It's there? Shall I leave it up? Yeah. We'll carry on. And if you want to leave, we won't be offended. All right. Thanks.
For accepting this research for presentation at ICS. The research is entitled Perineal Trauma in Subsequent Delivery After Previous Obstetric Anal Sphincter Injury, a multi-centre study. The research was carried out at University of Southampton, and there were 4 different NHS sites involved in the research. The objectives of this research were to investigate the birthing outcomes at subsequent delivery after obstetric anal sphincter injury, or OAC, and to explore what factors influence the risk of recurrent OAC. The design was a retrospective analysis of prospectively collected data and a comparison of maternal, intrapartum and neonatal factors between those sustaining recurrent OASIS with those whom did not. And the selection criteria was primiparous women sustaining OASIS during singleton term cephalic vaginal delivery whom had a subsequent delivery. And the time was between 2004 and 2015. So within that time period, there are around 86,000 primiparous term singleton cephalic deliveries with an OASIS rate of 5.8%. Around half of these women went on to have a further delivery, and 3/4 of those had a vaginal delivery with an OASIS recurrence rate of 10.2%. So the primiparous rate was start that slide again. So the recurrent OASIS rate was 10.2%. This is 1.8 times the primiparous rate and 8.5 times the multiparous rate. The most common birthing outcome was a second-degree tear in around 60% of the population. The rate of medial lateral episiotomy was 15.6%, and around 3/4 of those who had medial lateral episiotomy had no other trauma, sustained no other perineal trauma. And only 4.4% of those with a recurrent OAC had a medial lateral episiotomy. So now we're going to compare those that had a vaginal delivery sustaining an OASIS versus those whom did not. The left-hand column shows those that had an OASIS at subsequent vaginal delivery. There was no difference in the ethnicity of the ladies. However, those sustaining OASIS at subsequent vaginal delivery were more likely to be older at the first index delivery and at the subsequent delivery. No difference was seen in the weight of the babies at index delivery. However, those sustaining OASIS at subsequent vaginal delivery had heavier babies at the subsequent delivery, with a greater proportion over the weight of 4 kilograms. Statistical significance was seen in the grade or degree of OASIS at first delivery. Those that had a more significant degree of OASIS at the first index delivery were more likely to have a further OASIS at subsequent vaginal delivery. Those that sustained OASIS at subsequent delivery or had a recurrent OASIS were less likely to have had a medial lateral episiotomy, and that's regardless of the mode of delivery that the women had. No statistical significance was seen at any of the following. Factors independently associated with the risk of recurrence in OASIS after binary logistic regression are as follows. Age of mother at subsequent delivery, if the birth weight at subsequent delivery was over 4 kilograms, the degree of OASIS at initial delivery, and the use of episiotomy at subsequent delivery. Having a baby over 4 kilograms increased the risk of sustaining recurrent OASIS by 2.5 times. Medial lateral episiotomy reduced the risk of OASIS by 80%. The number needed to treat The number needed to prevent one OASIS was 8 medial lateral episiotomies, 10 in normal deliveries. Factors independently associated with the risk of recurrent OASIS after binary logistic regression are shown below. Having a baby over 4 kilograms at subsequent delivery increases the risk of recurrence by 2.5 times. Whereas medial lateral episiotomy reduced the risk of recurrent OASIS by 80%. The number of episiotomies needed to be performed to prevent one OASIS was 1 in all deliveries and 10 in just normal vaginal deliveries. So the conclusions of this are that the risk of recurrence and potential resultant symptoms of anal sphincter defect are far greater than previously thought. Current guidelines quote the risk to be 5 to 7%, whereas this study showed the risk of recurrence to be 10.2%. Positive predictors for recurrence are increased maternal age and birth weight at both deliveries, and severity of tear at the index delivery. More liberal use of medial lateral episiotomy could significantly reduce the risk of repeat OASIS. Many thanks.
And thank you for staying on to the bitter end, everybody. And feel free to ask me any IUGA questions if you wish. I can do that for you.